and I'm going to talk to you about whether the clinical indications of Desflurane are justified. A little bit about myself before we go any further. I'm currently the National Fellow in Environmentally Sustainable Anaesthesia, working between the Newcastle Hospitals, the Association of Anaesthetists, and the Centre for Sustainable Healthcare. A disclaimer, I'm not as experienced as a lot of other clinicians, and this is in no way a criticism of anyone's technique, nor am I telling people what to do. Neither am I funded by any drug companies. Now, for the next 45 minutes, I want you to forget everything you know about Desflurane and keep an open mind. So let me tell you about a wonder drug. It's 1991 and a new drug is coming to market. The British Journal of Anaesthesia has just published an exciting article. So let's turn ourselves back to the early 90s, and this was the time when Terminator 2 was coming onto our screens. We had Macaulay Culkin starring in one of our favourite Christmas films. Mr. Blobby was prancing around, and then there was this thing called the VHS or a Walkman. This was the same time when that wonder drug was about to come to market. And this wonder drug in 1991 was the new halogenated ethyl methyl ether, more commonly known as Desflurane. 1 year before, in 1990, the British Journal of Anaesthesia reviewed and promoted Desflurane. Overall, it was promoted as a drug that had potential benefits over isoflurane. It had no irritating odour, it had a rapid onset, a rapid offset, a reduced time to awakening, a reduced cognitive dysfunction postoperatively with a clear-headed recovery, and a similar metabolic pathway to other volatiles involving the P450 system. And Desflurane had an incredibly low metabolism. Is this not the ideal anaesthetic agent that we were all after? As we go through the rest of this presentation, I would like you to consider this principle in the back of your mind, the triple bottom line. In order to understand value of products that we use, we shouldn't just look at the economic costs, but the environmental and the social costs, and how this relates to patient outcomes. But if we take a step away from Desflurane for a moment and look at something different, something that we commonly use as clinicians on a day-to-day basis, if we look at paracetamol, the oral preparations versus the intravenous preparations, and we know that the outcomes for the patients overall are the same, as in it's a good, effective analgesia. But if we look at the economic environmental impact, paracetamol intravenous can cost roughly £1, whereas a oral tablet preparation can be as cheap as a penny. And the environmental impact of the intravenous has a considerably higher carbon footprint, with the liquid solution being prepared, the gas that it's stored inertly with, the glass ampule, and then the transport cost as well, with the increased weight and increased bulk in comparison to the smaller, easily prepared, less intensive preparation of a tablet form of paracetamol. So we can say that the overall value of oral paracetamol is higher than the overall value of intravenous paracetamol. So let's go back to Desflurane, and let's talk through each of the points to which Desflurane was promoted. So initially we mentioned that there was no irritating odour. So it was promoted as an agent that provided no irritation, and with its low blood gas solubility, surely it would have been the best induction agent out there. And we all know that this has not been the case. Shortly after its release in 1992, there was a review highlighting the high incidence of airway irritation, breath holding, coughing, and laryngospasm. So let's move on to the respiratory system. A randomized controlled trial in 2000, that can be seen on the left side of this screen, investigated the airway resistance associated with Desflurane versus sevoflurane, and it showed that there was an increased airway resistance in the first 10 minutes with Desflurane use, and in comparison with sevoflurane had a 15% rate of bronchodilation. And for those that smoked, Desflurane had even worse outcomes. A subsequent study, a decade later, published in the British Journal of Anaesthesia, that can be seen here on the right of this screen, studied 71 patients. It compared 3 commonly used volatiles and their effects on the airway resistance at differing max of 0, 0.5, 1, and 1.5 max. I've highlighted Desflurane and sevoflurane here on the right, and we can see that Desflurane was the only agent to show an increase in airway resistance at 1.5 mac, particularly in the first 10 minutes, but persisted for around 30 minutes before settling back down to its baseline. Overall, we can say that airway resistance at mac of 1 did not change for any of the agents. In conclusion from these 2 studies, we can say that the overall airway resistance at the beginning of anaesthesia with Desflurane had a worse outcome than with the use of other volatile agents. So the rapid onset and rapid offset attribute initially highlighted or promoted with Desflurane. Will Desflurane allow a faster recovery of airway reflexes? So from the day I started my anaesthetic career, I've learned the DAS guidelines for safe extubations. And I'm sure that most people in the audience, until they've become more confident with extubations, tend to use this guideline. The DAS extubation guidelines give us an indication as to when we should be extubating, and I've circled 2 key areas that I've learned since day 1, and they're circled in the red marker pen. The first is wait until awake, so eye openings or obeying commands, and secondly, checking airway patency and adequacy of breathing. And we all know that Desflurane from our use does give us that faster wake up and faster recovery in theatre, but does it mean anything? Is it clinically significant? So we can explore this a little further with the rapid onset and rapid offset. And there have been a number of studies that have shown that Desflurane has shown a faster return of airway reflexes, and this has been standardized or determined by a standardized test of time taken to safely swallow water post-anesthesia. But I believe this in itself has its own limitations. Each of these studies do not explain how slowly they reduced the Desflurane or sevoflurane, so it can only be assumed it was turned from a MAC of 1 to 0 at the very end with high flow rates in order to wash out the volatile gases. So is there another way to reduce wake-up times? However, if we look at the randomized control trial from 2020, published in this Scandinavian journal, it explains that the inspired volatile concentration was adjusted to maintain a BIS level between 45 and 50 intraoperatively. And then 15 minutes prior to the end of the operation, the BIS levels were maintained between 50 and 60. From this, there was no difference in wake-up times between the use of sevoflurane and Desflurane. The weakness to this particular study was that it was all on LMA maintained airway patients. The next attribute was reduced cognitive dysfunction postoperatively with a clear-headed recovery. The most substantive review was a meta-analysis done in 2005 comparing the recovery of sevoflurane against Desflurane. This was a 25 RCT study done by Macario and his colleagues, comparing roughly 750 patients receiving sevoflurane against roughly 750 patients receiving Desflurane. And they received either agent for up to around 3 hours with an average anaesthetic time of 1.5 hours. And it showed that the Desflurane arm were obeying commands just under 2 minutes sooner. They were extubated just over 1 minute sooner. And they were orientated in just a little under 2 minutes sooner in comparison to with sevoflurane. However, there was no significant difference in the overall recovery times. So they were all waking up and being extubated sooner with desflurane in comparison to sevoflurane, but it had no overall difference in the actual length of stay in recovery. So does this affect the outcomes? If we are not able to titrate down our anaesthetic agent, our desfluranes or our sevofluranes, to give a faster wake-up time to our patients at the end of anaesthesia or surgery, and desflurane is really good or is wonderful at waking patients up without titrating down, does this mean desflurane reduces our postoperative respiratory complications in comparison to other volatile agents? So the top article is a recent 2021 single-centre, multi-decade retrospective cohort study, and it analysed over 100,000 patients, and it showed there was no difference in the use of desflurane and sevoflurane between the rates of postoperative pulmonary complications. And it looked at two outcomes. One was early postoperative desaturations, and the other was the need to reintubate within 24 hours. And it found that there was no difference between these two groups. It did find that between the two groups, there was an average 6-minute difference in the length of stay in recovery, but this was not clinically meaningful. And these findings also translated into the higher risk groups. The higher risk groups being those with BMI of greater than 35 or patients over the age of 65. On the other hand, a 2020 meta-analysis that can be seen at the bottom of this screen is a European Journal of Anaesthesia publication looking at 13 RCTs, and it showed desflurane had worse outcomes. It had worse outcomes despite having a faster time to eye opening, and the faster time to eye opening was one of the parameters that we mentioned previously in the DAS guidelines for safely extubating patients. It found that patients were at significantly higher risk of adverse respiratory events when anaesthesia was maintained with desflurane versus sevoflurane at a rate of 20% versus 12%. 20% for the desflurane and 12% for the sevoflurane arm. And the predominant subgroup risk that this was applied to was those having their airways maintained with a supraglottic airway device. The limitations in this study were that it didn't actually tell us what the respiratory measurements were, so it's unclear how to definitively come to conclusions from this. Something that is commonly said to me is that I need a faster recovery in my OSA patients, my obstructive sleep apnea patients, hence why they use desflurane. So this 2021 RCT compared desflurane to sevoflurane, and it found that there was no difference in the apneic episodes between these patients. And as a side note, what was interesting was that there was observed apneic episodes up until day 3, rather than the first day post-operatively that we tend to focus on. Ultimately, up until now, what I've attempted to do is find journals comparing desflurane against other volatile agents, namely sevoflurane, to show whether there is or there has not been any difference in their uses. But if we go one step further and compare desflurane with propofol, TCI, propofol has been shown to have a more favourable recovery profile. This 2020 randomised controlled trial in the British Medical Journal showed early ambulation that was defined as walking 10 steps in less than 12 hours after the operation, and a shorter length of stay in the propofol group was found in comparison to the desflurane group. Patients with propofol anaesthesia had a length of stay of 3 days in comparison to desflurane patients who had a length of stay of 4 days. So what does this all mean so far? So to summarise, patients overall have a faster wake-up time with desflurane, as we know from our clinical use, but if other volatiles are slowly titrated down, they can be just as effective with reducing recovery times. Does desflurane reduce rates of postoperative pulmonary complications? No, but desflurane has been found to have worse outcomes. Will the use of desflurane improve patient turnover in a list? No. Will it reduce recovery lengths of stay? No. And propofol has a favourable recovery profile? Yes. Now let's talk about obesity. Obesity is not just an anaesthetic struggle. Obesity is becoming increasingly prevalent. And this is a map of the northeast region where I'm currently working. But if we, as a nation, look at this, our 2020 data in England shows that 68% of adults are overweight, and obesity affects 28% of the population, and morbid obesity affects 3%. So if we break this down into age groups, as can be seen on the left on the graph, obesity affects more than 30% of over 35-year-olds. And our population isn't getting any younger. In the northeast, where I'm currently working, in 2018 to 2019, the prevalence of being at least overweight was greater than 60% in the Tyne Wear region. And obesity will continue to have an increasing challenge, will pose an increasing challenge in hospitals and within anaesthesia. So let us very briefly talk about the pathophysiology of obesity and its relation to an anaesthetic. So we know that with an increased tissue mass, there's an increase in oxygen consumption. As a consequence of that, there's an increase in CO2 production. To maintain normal capnia, the minute ventilation needs to increase. The minute ventilation increases with the increased chest wall weight against it. As a consequence, there is a reduction in the functional residual capacity, or the FRC. As the FRC continues to decrease or diminish, it decreases below the closing capacity. Once the closing capacity is greater than the FRC, it results in atelectasis, and that can lead to a VQ mismatch, resulting in difficulty with oxygenating our patients. If we move on to the cardiorespiratory system, with a decrease in oxygenation, there would be an increase in our hypoxic pulmonary vasoconstriction. This results in pulmonary hypertension and increase in right heart strain. From the purely cardiovascular side, there would be an increase in circulatory volume and cardiac output in order to meet or maintain the oxygen demands of the body. This is as a consequence of increasing the stroke volume, which then results to left ventricular hypertrophy. This overall inevitably results in a challenge for us in theatres for both the anaesthetic side and the surgical side. So will desflurane provide a superior anaesthetic technique for our obese patients? So this is a very busy slide, and I've highlighted the three key areas here, and it's isoflurane, desflurane and sevoflurane, with the relevant blood gas and oil gas partition coefficients highlighted for the respective gases. So to answer the question of whether the anaesthetic agents, or which anaesthetic agent is best for our obese patients, we need to take a step back and unfold our understanding of volatiles. So in 1975, there was a Dr. Fisher and their colleagues which documented the theory of obesity in relation to anaesthesia. They said that there was an increase in adipose tissue would act as a storage site for volatile agents, therefore resulting in a prolonged anaesthetic recovery. And the physical-chemical property to explain this is the oil gas partition coefficient. And we can see that desflurane has the lowest of our commonly used agents with a coefficient of 29. And this is how we've all been educated for our exams, and the knowledge has been passed from one generation of anaesthetists to the next, and so on. So we can see that isoflurane and sevoflurane have similar numbers, 98 to 80. But the emergence in the obese for sevoflurane patients is considerably faster. So is there something more to it than just the lipid solubilities? Possibly. There is a suggestion that the blood gas solubilities can be the dominant determinant in morbidly obese recovery rates, and we can see that sevoflurane lies closer to desflurane with our blood gas solubilities. So why can't fat act as a store to delay recovery of anaesthesia? The newer theory goes that the capacitance for fat in both the obese and non-obese is too large to become saturated, and studies have shown vessel-rich groups remain the same between obese and non-obese, rendering our initial theory of the importance of the oil-gas partition coefficients as less substantial. But how does this translate clinically into our practice? So I mentioned earlier in a previous slide there was a 2021 single-centre multi-decade cohort study analysing over 100,000 patients, showing there was no difference in the use of desflurane and sevoflurane between the rates of postoperative pulmonary complications. And these results also translated into patients with a BMI of greater than 35 or those with deemed at higher risk. Here we have another study. This was a 2005 RCT whereby patients had an average BMI of 37, and it demonstrated similar emergence times when the levels of desflurane and sevoflurane were titrated down in the last 15 minutes of surgery. There was a similar emergence between the two groups, and this was despite a greater than twofold difference in the fat solubilities between the two, and the fat solubilities being 29 to 80. And they managed this emergence safely by using a depth of anaesthesia monitoring, a BIS monitoring. And if we compare sevoflurane to desflurane on the respiratory system, we know that desflurane is a bronchoconstrictor, as mentioned previously. And if we need to increase the depth of anaesthesia above a MAC of 1, then desflurane will also have will create a worse respiratory compliance. So if we use desflurane in this group, in this at-risk group, will this not make ventilating our patients and maintaining their saturations more challenging? So we know that sevoflurane can be titrated down to give the same end result as desflurane, but some of us may not be overly convinced by this. And this is, again, one of the common responses that I get. I've used sevoflurane and it just doesn't provide the same wake-up response. So is Tiva the alternative? If Tiva is our alternative approach, is Tiva endorsed by our superior powers? These are the most up-to-date guidelines, as far as I'm aware, from the 2015, coming from the Anaesthetic Association and Society for Obesity and Bariatric Anaesthesia. Ultimately, they haven't endorsed its use. And we can see their rationale in a bit more detail. There is a lack of evidence as to the best weight scaler to use with TCI techniques, and when used with neuromuscular blocking drugs, awareness is a significant potential risk. In these situations, some form of depth of anaesthesia monitoring is strongly recommended. To me, this does not sound all too reassuring. So let's briefly talk about the Tiva models this outcome was based upon. So now I'm not a Tiva expert, but let's very briefly talk about the different models. And before doing that, we just need to appreciate that in obesity, we should be using lean body weight drugs, lean body weight drug dosings, rather than total body weight dosings, as the obese populations have similar lean body weights to the non-obese. And using a total body weight dose can result in an overdose. So these models, the Marsh and Schneider models, are not representative to the actual population. The reason is because the way the algorithms were taken from the study groups. The Marsh data was taken from 16 patients and then prospectively validated in 66 patients. Whereas the Schneider model was taken from 24 patients. So both Marsh and Schneider had very small sample groups, and they were all taken in a healthy adult population. So if we talk about the Marsh model, we can use total body weight calculations, which in slim patients correlates very closely to lean body weight. Therefore, we give the doses needed to achieve desired effects without too many complications. But in obesity, the actual weights dialed in can result in an overdose because we're ultimately only interested in the lean or interested in giving lean body weight doses. As a consequence of giving too much anaesthetic or giving the total body weight dose rather than a lean body weight dose, it would result in cardiovascular instability. The way around this is to use an adjusted body weight, which I haven't shown here, but I am more than happy to share the details with if anyone desires. Next is the Schneider model, and this uses patient demographics, their age, their sex, and their height. And the system calculates the lean body weight by compensating for an increasing age. This results in an appropriate dose in the majority of the cases. And however, in obesity, the system paradoxically miscalculates the lean body weight, making the system unreliable. Then there is the alteration in the K10, the metabolism and the clearance. And this results in a higher maintenance dose. Therefore, for the maintenance of anaesthesia, there is too much being given for the obese population. There are many concerns behind these models, and that's why there has been apprehension with its use. But there is a Tiva solution, the eleveeld model. The eleveeld model has recently just come out towards the end of the last decade in 2019. This is a model tailored to the needs of the complex pharmacokinetic population. It utilized 30 pharmacokinetic studies and 5 pharmacodynamic studies. It was used on varying age ranges from half a year old to patients towards the end of the 8th decade of life. And it varied on patients being half a kilo to 160 kilos. It utilizes their age, their sex, their weight, and their height as parameters. It balances the dose given in the presence of opioids, and it predicts the propofol concentrations for a broad, diverse population. And this is the paper for those of you that may be interested. So in summary, for the obese population, Desflurane affects the physiological ventilatory function more so than other volatile anaesthetics. Desflurane can provide a faster recovery time, as we clinically know from our everyday practice, but if sevoflurane is titrated down at the end of an operation, there is no benefit through the use of Desflurane. Adjusted Marsh models have been used by many anaesthetists with good results. And the newer Tiva model, the eleveeld, puts to bed concerns of the previous models and their algorithms. However, it is still undergoing multiple reviews. Now, if we move on to the cardiovascular impacts of using Desflurane, we know that Desflurane and sevoflurane reduce blood pressure but improve blood flow through coronaries, hepatic, intestinal, and skeletal groups. A 2010 study compared Desflurane, sevoflurane, and isoflurane, and it showed that overall there were no differences between the effects on diastolic function, but possibly Desflurane provided some degree of diastolic preservation. Again, the clinical significance of this is unclear. Desflurane, like all other volatiles, are arrhythmogenic and can increase the risk of prolonged QTc, whereas propofol is less likely to do this. Isoflurane, Desflurane, and sevoflurane for carotid endarterectomies have shown that there is no difference in ST segment changes, and this was found in a paper done in the year 2000 by Umbrain and his colleagues. A 2007 meta-analysis showed volatiles were better than Tiva in cardiac surgery with respect to reduced rates of MIs, and it found that there was a 2% associated MIs with the use of volatiles against a 5% rate of MIs with the use of Tiva for patients in cardiac surgery. So we're now on to the points of desflurane having a low metabolism and similar metabolic pathways to other volatile agents involving the P450 system. But is desflurane the safest to be used in liver disease? So the traditional agents, such as halothane and enflurane, are metabolized or were metabolized to hepatotoxic trifluoroacetylate, TFA. TFA is known to trigger autoantibodies causing volatile-induced liver injury, or the injuries associated with the use of halothane that we commonly used to be aware of, and hence we have moved further away from. But desflurane has minimal biotransformation, therefore there is less theoretical risk of volatile-induced liver injury. But sevoflurane has no toxic TFA. It undergoes no biotransformation, therefore the theoretical hepatotoxicity potential is the lowest in comparison to all the other volatile agents. But does this actually mean anything clinically? So if we look at liver transplants, and liver transplants undergo a lot of stress. There is a potential for ischemic time, and any form of ischemia can result in oxidative stress. Oxidative stress produces free radicals, and these free radicals can overcome the endogenous antioxidant defenses within the body, and this can impact or can lead to cell damage and mitochondrial damage. And any organ transplant, as I've mentioned, can have a risk of ischemia, particularly in liver transplants, because within liver transplants there is a post-reperfusion syndrome, and it has been known to be with post-reperfusion syndrome increased morbidity. And desflurane has been shown to have a less desirable outcome versus sevoflurane, and this was a 2016 study which showed that desflurane use was associated with a 77% post-reperfusion syndrome compared to 38% of whom received sevoflurane. These rates resulted in an increased length of stay within hospital, but importantly, there was no overall end difference in mortality. So I've said that ischemia can overcome the antioxidant defenses, and one way to prevent this is to increase the number of antioxidants. Propofol is an antioxidant with its structure making it similar to the endogenous antioxidant vitamin E. Therefore, propofol could provide theoretical protection against ischemic events, but there are no studies to date to give conclusive evidence of this, an area of further potential research. So the next question is, within liver disease, what about liver malignancy resections? A British Journal of Anaesthesia article in 2019 showed a significant outcome. It was a single centre RCT looking at HCC outcomes, showing those anaesthetised with propofol rather than desflurane had a 50% lower rate of death, and the chances of reoccurrence were lower. However, the limitation was that despite matching, the tumours were smaller in the propofol group, but nonetheless, this was a substantial difference in the rates and the outcomes. So if we move on to the kidneys, is desflurane nephrotoxic? So we know that the degree of kidney impairment depends upon where we're starting from, and it differs from operation to operation. Does the patient have a chronic kidney disease and acute kidney injury before the operation? What is the type of operation that the patient is going to undergo? Can have a bearing on the extent of renal dysfunction postoperatively. In a retrospective study in Korea in 2012, comparing over 200 patients, it showed there was no difference in postoperative renal function whether desflurane or sevoflurane was used, and this was done in live donor nephrectomy patients. And then a subsequent study in 2019 showed that an observational study comparing over 1,000 patients that was split into 3 arms, being propofol, desflurane, and sevoflurane, and when it took into all the variables, the propofol group had less rates of postoperative renal dysfunction, but there was no difference in the renal dysfunction between volatiles. And looking further down the line, the 3-year rates of chronic kidney disease in the propofol group was lower than that of the volatile arms. On the other hand, smaller studies have looked at other operations looking at propofol versus the volatile differences with renal dysfunction postoperatively, and it showed that there was no significant improvements with propofol. The take-home message is that there are alternatives with desflurane which have possible better outcomes, but most importantly do not have worse outcomes. Does desflurane decrease post-op nausea and vomiting rates? We know that post-op nausea and vomiting depends upon many patient and surgical factors, and also our anaesthetic factors need to be taken into consideration. So volatiles, whether it's desflurane, sevoflurane, isoflurane, they all reduce cannabinoid neurotransmitters. As a consequence, this results in post-op nausea and vomiting. And there is no difference in the types of volatiles, as I've mentioned, but Tiva could be an alternative and is something that is already done so for our patients with severe risk or known to have severe post-op nausea and vomiting. Other points of consideration: cerebral homeostasis. There are similar results with the use of desflurane against sevoflurane, but importantly, isoflurane has worse outcomes in comparison to desflurane and sevoflurane. DNA damage has also been studied with the use of desflurane, and it has been shown that there are higher rates of DNA damage, but the clinical significance of this is unclear. So earlier on, we spoke about how desflurane was promoted, and now we've been able to look at each of these, plus more, and prove or discredit them. So earlier on we mentioned there was no irritating odor, a rapid onset, a rapid offset, a reduced time to awakening, reduced cognitive dysfunction post-operatively with a clear-headed recovery, similar metabolic pathway to other volatiles, and incredibly low metabolism. The reality with desflurane is that it does have a pungent smell. It does have a fast onset and fast offset that we know from clinical use, but this makes no clinical difference, and anaesthetic techniques can offset this. Desflurane can worsen underlying respiratory disease because we know it's a bronchoconstrictor. Desflurane does not reduce postoperative pulmonary complications despite having a faster offset, and can in fact worsen postoperative pulmonary complications. There is no improvement in theatre efficiency with the use of desflurane. There is no clinically significant difference in the length of stay in recovery. There is no difference in cognitive, or there is no clinically significant difference in cognitive function post-recovery. And in the obese patients, the faster offset can be achieved with BIS monitoring and gradual titration down of other anaesthetic agents. And there are some reports that the use of desflurane has a worse outcomes in malignancy with respect to HCC. To look at the value of desflurane, we mentioned earlier on the triple bottom line, and we've spoken about patient outcomes with respects to the clinical parameters. But if we wanted to look at the value of the agents that we use, we need to also consider the economic environmental costs. And if desflurane, and the question is desflurane cheaper, and is it more friendly for the environment, at least if it is not going to have the benefits clinically? So the environmental costs of desflurane. Desflurane is 3 times less potent than sevoflurane to achieve the same clinical effect. This means 3 times more desflurane by volume is required in order to achieve that same clinical effect. Desflurane is 20 times more toxic for the earth than sevoflurane. The CO2 equivalent per milliliter of liquid of sevoflurane is 0.17 kilograms of CO2 equivalents per mil, and desflurane is just over 3.5 kilograms of CO2 equivalents per milliliter. As a bottle of desflurane, being 240 milliliters, this is just under 900 kilograms of CO2 equivalents. And this is the equivalent in everyday use of a meat eater having 10 weeks worth of shopping, or if you're going to go on a nice travel, a 3,000-mile return trip from London to Naples in a small petrol car. So what does all of this mean? So climatically, if we don't change, then the northeast region, in particular with Newcastle, where I'm currently living, parts of Newcastle will be underwater. Maybe your hometowns may have flooding similar to that seen in Germany in the summer of 2021. We will lose the remarkable sequoia trees in North America seen on the left through the forest fires that ripped through Western America last summer in 2021. And maybe the future of coral reefs may be a lifeless one. We know that climate change affects our planet, but it also directly affects our health. There are many factors to consider here, but a couple of examples would be a worsening air pollution can lead to cardiorespiratory disease. Then there are changes in temperatures and living conditions, which result in the increased prevalence of diseases. Impact on the water supply can cause malnutrition, and the list does go on. So we've looked at the environmental side, but if we look at the economic side, is desflurane at least cheaper? So the cost of sevoflurane is 21.6 pence per milliliter in comparison to desflurane, which is 32 pence per milliliter. So a bottle of desflurane is £77 in comparison to £54 for sevoflurane. And we said earlier that we need to use 3 times as much desflurane in order to achieve the same clinical effect as sevoflurane. Therefore, the take-home point here is for £1 spent on sevoflurane, you would have to spend £4.49 of desflurane to get the same clinical effect. These are prices taking the Freeman Hospital at Newcastle's pricing regime for the years of 2020 to 2021. But I suspect that throughout the country, the prices will be relatively similar. In conclusion, desflurane is the most expensive, environmentally toxic agent and provides no clinical benefit to our practice. It has, in my opinion, no place in our anaesthetic room. Thank you. All questions are welcome at envirofellow@anaesthetists.org.